Good morning, everyone, and welcome to Within's Continuing Education webinar series. My name is Ashley Barkowiak, and I'm the Clinical Operations Coordinator here at Within Health. We have so many exciting events to come through this year during our webinar series, including the webinar that we have for you today. Today, I would like to introduce you to Esther Hooley, who is a primary therapist here at Within, and also an author who will be presenting on the topic of sexuality and eating concerns, clinical considerations. Esther has been a therapist for over a decade and is currently a licensed psychologist in Texas. She completed her doctoral degree in counseling psychology at Andrews University and completed her doctoral internship at Baylor University Counseling Center. For years, Esther has considered herself a generalist, working with any issue that showed up in the counseling space. More recently, she has developed a passion for working with sexual concerns, eating disorders, trauma, and spirituality concerns. Esther has a personal and professional investment in social issues and is intentional about promoting hope and justice in the clinical work that she does. She approaches therapy into account each person's intersecting identities and then tailors treatment to allow the whole self to be present and honored. Esther draws from multiple modalities, including CBT, DBT, relation, interpersonal, and narrative, while working with the clients. Her approach involves identifying and disentangling long-standing patterns of feeling, acting, and thinking that keeps a person's distress in place and are typically the product of relation wounds. Esther's goal is to help clients examine and challenge these patterns and to identify new ways of being that provide clients the ability to authentically connect with and belong interpersonally and interpersonality. Her work is collaborative and creates emotional safety where each client can engage in vulnerability, increased insight, and take practical steps to heal. Before we have to start things off, I do have some general information to go over in regards to the CEU and CME credits. I will now pass things over to Jamie, and she is going to go over the CME credits for you all.
Thank you so much, Ashley. Hello and welcome, everyone. Just want to introduce myself. My name is Jamie Singletary, and I am the Director of Clinical Brand Development for Within Health. And when it comes to the CME credit, for those of you that are looking to obtain the CME, I am going to put my email in the chat so that you can email me and I can send you the directions and the code for your CME certificate. Thank you.
Thank you, Jamie. For the CEU credit, evaluations will be sent to the email that you used for registering for this presentation. Once the evaluation is completed, you will receive a link to download your CE certificate. Please utilize your CEGO dashboard for all things CE related. A video of the presentation will also be available 24 hours after here. You will not get credit for just watching the video. You need to attend live in order to receive credit. To access that video, please also utilize your CEGO dashboard for that. If you have any technological issues and need to change devices during the presentation, you will receive credit. For any additional questions, concerns, or obtaining the CE credit or the CME credit, I will provide my email as well as Jamie's and the CEGO support information in case you need any of that. Also, feel free to add any questions that arise during the presentation to the chat. We will not be sharing the slides today. However, the recording will be available to review any of the material that is being presented today. So again, welcome everyone, and we are so excited, Esther, to have you here presenting today.
Thank you. Welcome everyone. I'm so excited to be talking to you today about this. A couple of things before we dive in. One, I want to recognize that language around sexuality and gender is constantly evolving. However, today some of the language I am using might be dated, and that's intentional. It's just to honor the language that was found in the research I gathered. So I just wanted to take note of that. Also, I will not be addressing the intersection of sexual trauma and eating disorders today. That is, maybe a 3-day conversation to be having, and we have an hour. So just one little limitation with that today. I do want to go over the objectives. Hopefully by the end of our time, you'll be able to name three ways in which eating disorders and sexuality are connected. You'll feel like you have increased knowledge in linking eating disorders and gender dysphoria. You'll have a greater understanding of assessment of sexuality concerns, And also at the end, we'll take some time to explore potential biases that that we might hold related to sexuality. So let us just dive in. So I have some words up on the screen here, and I wanted to add these in because in my experience, these are the parts that disappear when the eating disorder takes over. This same language, I think, also applies to what people experience as sexual beings. So, what this tends to bring to mind for me is that often to carry on with an eating disorder, a person has to cut off parts of themselves, parts of their sexuality. There's no more wanting, there's no more pleasure, no more satisfaction. Um, and I have found that, when I'm working with folks, sexual connectedness doesn't happen until the restoration process is well underway. So I just wanted to take note, these words, yes, they apply to food and appetite, but I think they're also connected to sexuality, and just wanted to take note of that. Some other ways in which eating disorders and sexuality are connected, both are a human drive. Um, and I'll add a caveat here, kind of, because people who identify as asexual may not have that same type of drive. I'll be talking about that in a presentation later this year. You're welcome to join that. And I want to note that, asexuality is a true and valid identity. Other sexual identities, do recognize that, sex is a drive, it's a need, it's a function. We need food to survive individually, and we need sex to survive collectively as a species. And both of these drives for both food and sex come from the same part of our brains, the hypothalamus. We know that both impact connection and relationships and intimacy. I always kind of hold this belief that, when working with eating disorders, it's not really about the food. And when I work with sexuality, it's not always about sex, right? It's typically about the emotions that are underneath the surface. Um, so for instance, I do work with couples, and when a couple comes into therapy, I often hear one partner saying that we're here and the goal of our therapy is to increase the frequency of sex. But about 95% of the time, we end up focusing not on the frequency or quantity, but rather the quality. And that involves things like connection and vulnerability and safety, more so than let's just focus on frequency. And I think we also know when someone presents for care due to an eating disorder, we're not investigating food, right? But we are looking at their internal world and where they have become disconnected from themselves and their identity. We also have multiple messages, both at a societal and cultural level about food and sexuality. There's often a right, quote unquote, kind of sexuality or orientation or expression, or body size, body shape, weight. And those types of messages take away our intuition about who we are as sexual beings, and also our intuition about food and hunger and when we're satiated. And so I find those things connected in that manner. Pleasure is also pretty central to both eating and sex, right? Pleasure and self-worth tend to be complicated for those with disordered eating, because the eating disorder tends to kind of lead us to believe that we have to earn pleasure, right? Or food, or we have to earn rest or fun, and that we are not just innately able to have those things. And that can also lead to a feeling of, well, I'm not deserving of a relationship or intimacy or relational nourishment, and fears that, what if my body is a burden to other people? And of course, the eating disorder will latch onto that and fuel that. For some, sex can become a behavior that leads to, this is how I accept pleasure. So I don't feel worthy enough, so I'm going to go find some semblance of that through a sexual relationship. And these thinking patterns that, I have to earn pleasure, or my worth comes from what my body can do sexually. These types of beliefs, do not lead to successful, meaningful, and intimate sexual experiences. I also want to talk about what we see in research. So it's been hypothesized that those with eating disorders who tend to be pretty emotionally constricted or over controlled, we often see this in patients with anorexia, they tend to report limited or constricted sexual functioning. Whereas those who have maybe more emotional dysregulation, which we see in binging and purging, um, tend to have low self-control and report more impulsive and chaotic sexual profiles. So we see an intersection at that point as well. Attitudes about the body impact sexual experiences, as we would expect. People with a healthy to neutral attitude about their own body have been shown to report more frequent sexual experiences and to engage in a wider range of sexual activities, as they tend to feel more desirable and self-confident. But the more dissatisfied a person is with their body, typically the more severe the sexual dysfunction, is or can become. And we also see a decrease in sex drive, for various reasons I'll talk about on the next slide. But what we do know is that as weight restoration occurs, there's typically an increase in opportunities for experiencing healthy sexuality. We have the drive back, we have the hunger back for that intimacy and that closeness. Some other things that we might note are the changes in sexual desire that can happen. And this is often due to decreased sex hormones, right, which leads to low sex drive, hypoarousal, loss of interest, difficulty becoming aroused or maintaining arousal, and general just a lack of pleasure in sex altogether. We also know it impacts sexual performance. I don't really like the word sexual performance, so I put sexual ability in there, because we often find there's a preoccupation with food or weight and actual or perceived body changes, and these are distractions, which again influence how present you are and your ability to enjoy a sexual experience. When an eating disorder is at play, we also know there's often moodiness or fatigue or lack of concentration, physical discomfort, GI issues. That coupled with these decreased sex hormones that can lead to discomfort, such as like vaginal dryness during vaginal sex or difficulty achieving orgasm, really impact a person's desire and ability to be sexually engaged. And then, of course, there's changes to sexual pleasure and satisfaction. Oftentimes I think there's anxieties co-occurring with an eating disorder, and an anxious brain is a hypervigilant and rigid brain. And that anxiety disconnects a person from their body. It disconnects them from a partner or a partner's body, and ultimately just a disconnection from pleasure as a whole. Moving into thinking about gender dysphoria and eating disorders, typically we see some high rates of body dissatisfaction. So, in eating disorders, that dissatisfaction is often rooted in the fear of weight gain or perceived body fat. And in gender dysphoria, that dissatisfaction is often focused on secondary sex characteristics that are discordant with an individual's gender identity. We know that transgender folks also have higher rates of dissatisfaction with body parts, and typically those body parts are not sex specific. So that might be something like facial features, body shape. And we also know there was a recent nationally representative study in the US showing that adults who identify as sexual minorities had between 2 to 4 times greater odds of experiencing a DSM-5 eating disorder diagnosis compared to their cisgender hetero adults, their peers. So there could be this link, this higher risk being linked to having a sexual minority status. It's something we want to keep in mind as we're working with patients. We also know that when that felt internal sense of gender does not align with the gender a body may present with, there are going to be higher levels of distress. And this clues us into the higher likelihood of disordered eating patterns. I want to turn to maybe how interactions of eating disorders and gender dysphoria, what those interactions might be, or how the eating disorder might mitigate or intensify gender identity distress. So through investigating trans non-binary folks' understanding of the relationship between their gender, eating, and body image concerns, research has given us kind of 5 different areas that are important and what we should consider in the conceptualization of eating disorders. So the first is gender congruence. We often see the function of the eating disorder connected to punishment in the specific group of people. For example, someone with that gender incongruence could use the eating disorder to perhaps punish their bodies for not being what they want it to be or presenting as they want it to be. And it becomes almost a punishment for who they are. But we can also see that it's used to create some gender congruence. So in this study done in 2022, a qualitative study, one of the participants said, if my body is too feminine in appearance, and by that this participant meant curvy, that's the language they used, they restricted to create a sense of gender congruence. So that is how the eating disorder, intersected with the dysphoria and incongruence they were experiencing. We also know puberty is impacted. So eating concerns can function as a means to stop puberty in childhood, early youth. Helps the person to avoid any body changes that could be read as gendered, and also gives them this sense of control over a body that often they feel has betrayed them. So in the same study, a participant noted, I can't control how my body presents, but I can control whether I care for it or I support its growth. Emotion regulation comes into play. So eating disorders can be used to regulate emotions, such as, if I pour my effort and energy into an eating disorder, I don't have much time to focus on the distress my gender has brought me. So it becomes a means of regulating that heightened emotional distress that can come with gender dysphoria. It's used in gender expression. The eating disorder can be used to meet social standards regarding what is, potentially stereotypically typed as feminine or masculine or androgynous. The eating disorder supports obtaining that gender expression that is culturally expected. So, for example, we know society, diet culture says, to be a beautiful woman, you must be thin. And so someone with gender dysphoria who's trying to find some congruence might say, well, to be a real woman, I must make my body thin. And so in that way, the eating disorder fuels expression. But we also know there's an interplay when it comes to recovery. We might see this like when a patient says, the more accepting I've become of my gender, the farther away I get from the eating disorder. And we see that the function of the eating disorder, it's no longer needed. I want to talk a little bit here about gender affirming care. I think we're all pretty aware of just that trans young adults really face some very significant stressors. Stressors like discrimination, barriers to accessing healthcare, peer victimization, family rejection, maltreatment, and on top of that, they're typically underinsured compared to cisgender folks. So this coupled with the politics, the legislation we've all seen. For instance, last year in 2023 alone, there were 576 bills regarding restricting care and access for trans non-binary folk across 49 states. And 83 of them ended up passing. And this legislation was put in place to literally keep healthcare from trans folk. And this essentially primes them for mental health concerns. If they don't have access to what they need, we know that sort of inability to receive care just deepens things like distress and depression and anxiety. As Ashley mentioned earlier, I reside in Texas, and last year there were 76 anti-LGBT bills filed. 20 of them moved, one passed. So in Texas now we've got legislation that has banned puberty blockers and hormone therapy for kids. There's restricted college athletic teams that trans athletes can join. And then, of course, you all are probably aware of, this season where Greg Abbott has asked that parents who are getting care for their kids, their trans kids, be reported to CPS. And so that has also greatly impacted the well-being of not just our trans non-binary folk, but their families as well. So I say all that to say, if gender-affirming medical care remains inaccessible, these folks may resort to eating disorder behaviors to manage the dysphoria. If they don't have access to hormone replacement therapy or puberty blockers, they will resort to what they have available to them, and that could be something that potentially has these lifelong disastrous effects. So I want to encourage you to take a moment and think about how you are providing gender affirming care in whatever capacity that you work with clients. And I wanted to give a couple examples here, and I know they might feel foundational, but it can look as simple as using a person's correct pronouns or their preferred name. Double checking the paperwork when you meet with them. Is this the name you go by? Are these your preferred pronouns? It looks like introducing your own pronouns, or many of us might. You can see I have got my pronouns up here on my Zoom screen. Having that when you're in meetings or in virtual spaces. And if you have a brick and mortar office, how could someone look around and know that you are a safe provider for them to open up to and to trust? So that would just be something to consider kind of as you look around your own space. How are you communicating safety in that way? I would also encourage us to just be mindful of language, using more gender neutral language. This has taken me a bit to adjust to, but I think it's just so valuable. So during my intakes, I tend to use words like siblings instead of brother and sister, or I say partner instead of assuming a boyfriend, girlfriend, husband, wife. I don't guess someone's gender based on their appearance. And this one has been the hardest one for me. I don't know about you all, but dropping that statement, you guys. I am not 100% perfect at that, but I have, tried to switch to using the term folks just to be more inclusive. And I think that's especially important if we're doing like group therapy and we don't want to assume who all is in the group or make anyone feel like they don't belong. So I wanted to talk a little bit more about maybe some different ways we can look at this connection between food and sexuality. So you'll see the quote up on the slide, "Food is sex," and that's from a pretty classic Freudian perspective, because he talked about it as pleasure being derived from eating, not just because of a sensory reaction or taste buds, but that we are actually driven by these repressed sexual impulses, which manifest in the craving of food or potentially binging. Kind of on the flip side, he went on to say that dieting and restricting could be seen as an attack on this unconscious drive and used to mediate the shame we feel for our sexual impulses. And, who knows? It's Freud. He did a lot of drugs. But what we do know is that neuroscience has documented really powerful effects that various foods have on mood, especially as it relates to the release of neurotransmitters such as dopamine, serotonin, norepinephrine, endorphins. And these chemicals, they make us feel pleasure and calmness, concentration, pain relief. And interestingly, sex also triggers the release of these neurotransmitters, right? Causing us to, crave a person like we might crave sugar. So we see that kind of interlocking there. I want to talk about attachment theory, which we could talk for a long time about attachment theory. I'm gonna keep it pretty short for today. But when we think about food and pleasure and attachment theory, that theory states that emotional support, understanding, empathy, acceptance during a child's development, especially early development, are the foundation of self-esteem and self-worth throughout life. And without those healthy attachments, our self-esteem tends to be diminished, and our capacity for empathy towards ourselves, towards those around us, often becomes impaired. And when this happens, a relationship with food or a relationship with sex can become this replacement or this metaphor for the healthy relationships that a child has craved. So food and body image obsession are the repeated need for sexual activity. And that validation provides a false sense of self-esteem, but it's how a person might measure their own worth. And it's a simple way to do that in a complex world. And when we know emotional, intimate human interactions tend to be quite complex. So being, quote unquote, attached to an eating disorder or to sex feels much less complicated than relational attachments. And so we can see then how food and sex become the safe attachments versus opening ourselves up to harm or vulnerability. I want to talk a little bit about how food can be used in conjunction with sexuality. So I'm going to talk about two different terms here. And if you've been working in eating disorders for a while, you've probably come across these. The first one is the term feedism, which I think you can also use the term feederism. But feedism is a sexual interest in being fed or feeding, often extending to an interest in weight gain and fatness. So it's commonly referred to as a kink. Some people call it an orientation, a lifestyle, and there are different roles that happen. So there's a feeder, so someone who is encouraging, aiding weight gain in a partner, and then there are feedies. So those are the people who are gaining weight and being fed. And I want you to take note, if this is a newer term for you, noticing just how your body is reacting to hearing this. If you're noticing any feelings, thoughts, whether it's positive or negative, just take note of those. Because I think with unfamiliar, we can often have like a reaction to push away versus to get closer and to get curious. There's a great website out there called Fetus for Fat Liberation that if you want to learn more about this and the community and the lifestyle, I would encourage you to go to that website. It's really informational and it's really positive. The next term is pseudophilia, or often that's called food play. So this is where a person has an erotic attraction to or becomes sexually aroused because of food. It can include sexual arousal caused by erotic situations involving food. The way that I often conceptualize this one is, if you're a millennial, you probably remember the movie American Pie, or that, whipped cream scene from Varsity Blues. And we can, that is a great visual representation for connecting the sexual arousal and food. So there's a lot more examples for us millennials, but I just picked the two most popular for us to picture. And that's some questions to just consider thinking about, and maybe even discussing with clients is, thinking about the connection between hunger and drive and how that shows up for a person. And then this last point here on the slide is something I've been thinking a lot about, just how we have been impacted by growing up in a world where we're told we need to earn our dessert, to earn the sweetness, the pleasure, the reward, and how we take that in our childlike brains, but then apply it to larger parts of our world as we become adults. So just something to note and maybe think about for yourself as well. So we're going to move into kind of the assessment phase of things here. And I added this slide because I think sexuality is often maybe put in a box or split into just like two very basic categories, like it's orientation or it's having sex. But it's much more than that. So I put this image up. It's called the 5 Circles of Sexuality. And I think it helps us see how so many different aspects of our lives are impacted by sexuality. And I want us to hold on to this image as we talk about introducing sexuality to patients and thinking about what we're really assessing. So you can look this up. I would encourage you, like, keep a handout somewhere where you can see it if you are someone who is assessing more about sexuality with clients, to really think about, okay, I'm thinking about sensuality and sexualization and reproduction and identity. Like, there are so many ways that we can learn how a person experiences and expresses sexuality. I also wanted to put up here how the World Health Organization views sexuality, and they see it as a central aspect of being human throughout life, and that it's influenced by these interactions of biological, psychological, social, economic, political, cultural, legal, historical, religious, spiritual factors. So I get excited when I see a sentence like that because there are so many ways we can enter into a person's story and learn about how sexuality has been shaped or how it has been used to shape other areas of a person's life. So to me, this is like, wow, there's so much freedom and so much creativity that can go into the assessment of this aspect of a person's life. I want to give you some more, I guess, generalized concepts about assessment with sexuality. The first is to assume that sexual complaints are often underreported. And I say that because you have someone coming in for an intake, let's say, and it's the first time you're meeting them, and then you ask about sexuality. They don't know you. There's not a lot of rapport built. Maybe they have their own discomfort around talking about sexuality. And so they might give you some information, but I often assume, I'm getting a very small slice of what's actually going on here. And so that's just something I hold in the back of my head, especially as I'm moving along in therapy with a person. Some things you can do is promote comfort and ease. So, if you have a brick and mortar office, this is where you want to think about furniture placement and how your room feels, how it smells, how it looks. You want to think about eye contact and, excuse me, and routinely checking in with your clients during this assessment process. How are you feeling about this? Are you doing okay? Because some people are much more uncomfortable talking about sex than we would imagine. We also want to provide a safe environment. So to me, that means creating the opportunity for discovering, normalizing, reframing things like attractions or sexual thoughts and feelings, fantasies, sensations, and to be able to allow space for the paradoxes that come up with sexuality and with gender, as both are often quite fluid. And many of us feel safest when we can put something in a box or make it black and white. And when we're talking about sexuality, it is the gray. We are living in the gray. And so being willing to have those paradoxes come up and be present and maybe not have to do anything with them. Some therapist considerations: we want to be aware of the, heteronormative assumptions and biases that, we've all been swimming in those waters our whole life. We want to be aware of how they might show up. We want to be respectful. We want to be non-judgmental. and, be aware of our own internal dialogue, and, our own arbitrations regarding sexual matters. With that, kind of moving into the next point, we want to know who we are as sexual beings. Understanding our own sexuality can be immensely helpful. We don't need to have done everything sexually to be able to provide support to someone. Rather, it's much more important that we are open-minded and we are educated about topics or know where to send someone to gain education about different topics. We want to be culturally competent, and we want to know our own sexuality. Who we are as therapists. We bring our whole selves into the therapy room. We don't just leave our sexuality outside at the door. That is coming in whether we want it to be there or not. So knowing our story, knowing our beliefs, our biases are incredibly important in this process. We want to avoid shaming. This is often done by just being very conscious about stating things neutrally, without judgment, stating things matter-of-factly. That can come across as inviting, of course, versus shaming. And we want to adopt a stance of both never assuming and always assuming. So I've learned that it's best to assume that everyone does everything, even though they may not talk about it. It's just much easier to start here and then narrow down as you get to know a person versus assuming this is a hetero person and they only do this and that, and that's what that means for them, and then having to grow out. So I think it's safest just to assume this person does everything. And at the same time, never assume that just because someone, a client is highly educated, has advanced degrees, all of that, that they actually know much about sex or sexual problems. Like you will still be the educator. You want to normalize sex talk? We do this through a use of, again, that like gentle, matter of fact, accepting style from the very beginning that we meet our clients. I think as we're able to consistently do that, there's this increase in them for their willingness to discuss sensitive information. We also want to think systemically. How do sexual concerns impact, not only this person in front of us, but their relationships or the other contexts that this person is in or may be in. And so we don't just want to think about the person in front of us, but think out more systemically. And then lastly, I don't have it on this slide, but I really invite people to be curious versus pathologizing. There are biases that we hold about sexuality, and they do lead us to stereotype. One of the most common ones I hear is that, if a person is involved in BDSM or kink, it's because they've had a sexually traumatic experience. That's a myth that's been debunked, unsupported in research for quite some time. I know the 50 Shades of Grey franchise really tried to give that myth a revival, but as strongly as I can encourage you, don't take any knowledge from the 50 Shades experience. But that's something that I think we almost naturally will think of, like, oh, well, there must be trauma there. And that's not always accurate. And, it's untrue for many people. And so we just want to be aware of a bias we might hold. Moving into a more thinking of like specialized assessment, I wanted to talk about the 6 Ps. I really like this. This is some guidelines based on CDC recommendations for sexual health assessment. So I'll walk you through these and give you some examples. We want to ask about partners, the number and gender of partners, nature of relationships. This is a great space to remember not to make assumptions about the gender of your client or the gender or identity of their partner or partners. We want to ask about practices. So what kind of sexual contact do you have? What parts of your body are involved when you have sex? Are you involved in sex work? What aids are used? Substance use. We want to ask about protection. Do you and your partner or partners discuss STI protection, methods used, how often they're used, preventative measures, and any current or past strategies for protection? We want to ask about past sexual history. So this is where we ask about STIs, maybe when and where they're treated, testing, all of that. This is also the place where I do ask about trauma. I don't use that language. I'll typically ask about any awareness of consent violations or an unwanted sexual experience. And really, I ask that question in a yes or no way, because typically the first session, that assessment phase, is not where we would want to dive into really talking or processing about a trauma. We're just taking that information and tucking it away and putting it in our conceptualization. We also want to ask about pregnancy. We want to explore without assumptions, discuss birth control as appropriate, assess for abortions or miscarriages, and then explore any family planning desires that a person might have. This is also a great place to remember that people who present as male can still have a history of pregnancy. And so it is just something we want to keep in mind as we're in this assessment process. And we want to assess for pleasure, right? Is this person satisfied with their sex life? Are them and their partners on the same page when it comes to sexual desire, sexual boundaries? What are the difficulties involved with sex? Is there pain or low desire or erectile dysfunction? And so using this as a framework can help you get a lot of information. And I think it's a pretty easy thing to remember, the 6 Ps. So we do know that there is empirical evidence demonstrating that evaluating sexuality is fundamental to obtaining a more precise characterization of the severity and prognosis of eating disorders. So, a more severe compromise of sexual health, both in terms of dysfunction, risky behaviors, may represent a more severe eating disorder. So, even though you may be working in eating disorders, assessing sexuality is still quite important. Some other things we can assess outside of the 6 Ps. We want to ask about reactions during sexual experiences. So this, I think, firstly, gives us an accurate evaluation that reveals, if a patient reports dissociative experiences during sexual activity or stimulation, or they're spectating, which is the act of observing yourself as a third person during a sexual activity. Those things are connected. There's a strong relationship between those and a history of sexual abuse. So that gives us some information about potentially the development of the eating disorders, as trauma and eating disorders are often linked. We want to think about risky sexual behaviors. This includes, I'm going to use this word promiscuity, but that's a very culturally dependent term and word, and so you'd want to really be curious about that. But we'd want to know about hypersexual behaviors that might, again, suggest the presence of a previous traumatic experience. And in these risky sexual behaviors, we want to think about attachment as well. So, because I think that can give us history or information about the history of attachment patterns, like whether it's used to regulate negative emotions or try to obtain closeness. We want to consider body image in this category as well. Severe dietary restraint is often associated with anorgasmia, low sexual desire, and so this is information that's helpful to know. When it comes to pleasure and reward, part of healthy sexuality is having our reward mechanisms functioning properly. So both sexual and eating behaviors are associated with the dopaminergic circuits within our brain. In particular, starvation, binging, purging, those have all been conceptualized as reward-driven behaviors. So when the eating disorder is present for some time, those behaviors are sustained, there tends to be an alteration in those circuits within our brain. And due to this alteration, these pathological eating behaviors like restricting or excessive physical activity and food-related cues start to become the only salient stimuli. So what we've typically thought of as rewarding goals lose their salience. And the severity of that compromise might hint at the extent of the damage of the reward systems. And so that's something to keep in mind as well. I know I said a lot of words, but you can just also assess on, do they feel pleasure? When do they feel pleasure? What gives them the most pleasure outside of sexual activity as well? We want to understand the severity of the compromise of sexuality. That's often associated with great distress and mental pain and depressive symptoms and relational isolation, all of which we see in the maintenance of an eating disorder. So I think it's important to know because it just creates a better understanding of kind of overall functioning of our patients. These last two pieces here on the slide, sexual timeline and sexual genogram, these can take some time, but I think, if part of your work is that it gives you time to do a sexual assessment, these are really interesting to do and can often reveal a lot. So a sexual timeline is basically kind of exactly as it sounds, and is just as simple as putting a line on a paper and plotting events from birth to current time. And some example of things that could be plotted would be, when was your first memory of sex or your first menstruation? When did you fall in love? When did you discover your body? And just kind of putting this narrative together of these, sexual moments in time and being able to be curious about them. What do they mean now? How are they impacting someone's functioning now? And then a sexual genogram. I will tell you, this is really time consuming, but maybe you're like a genogram lover and this is your jam, and go for that. So making a genogram, you would have just your regular, classic 3 generations if you chose that. But then you would also kind of add these pieces that would generate information about sexuality and scripting and love maps and the parental patterns that you saw related to romantic love, or cultural messages about sexuality or reproductive issues. And this would also be a place where you could explore like gender roles and, you know, who and when was their comfort or discomfort with sexual orientation or a sexual environment. And so this can go pretty in depth. It's not something I typically use, but it's a tool if you want it. So just wanted to bring it to your attention. I want to transition now to us as the providers. We, of course, have a significant impact on our clients from the very first meeting that we have with them. We are modeling what can be talked about, can't, and by this, we're really communicating about our own comfort or discomfort with certain topics. So there's this statement here below. I won't read all of it, but I will read, many physicians still avoid speaking about sex with their patients because of shame, or, maybe they hold this general belief that sexuality and sexual dysfunctions should be considered as secondary. But if you look at this last sentence here, there is empirical evidence suggesting that assessing the sexual health of patients with eating disorders can be useful. And hopefully you all have seen that throughout, the last 50 minutes we've been together, that we can get a lot of information by assessing sexuality, more so than just we're learning about orientation or sexual preferences. I think there are also other factors that play into whether we are more vocal or silent when it comes to sexuality and treatment. I think there's personal discomfort that can happen. Maybe we ourselves just aren't comfortable talking about sex. And like I said earlier, we bring our own stuff into the therapy space. And so, I would encourage you to start exploring that discomfort and getting closer to it, so that you can really show up in the therapy room. I think quite commonly there's a lack of training. In my graduate school experience, I spent 8 years in grad school, and I had one human sexuality course in my first year, and I don't remember a single thing about it. So, I've been taking other courses the past couple years to gain this knowledge, but a lot of us, don't know how to bring this up in the room because we just haven't been trained. And I think because of that, there comes this fear of like, well, if we bring up sex, we're crossing boundaries, or if I bring up sex, what if that leads to something else? And there's just this anxiety there. With that, I would really encourage you, like, seek consultation, talk about it with a colleague, and don't let that fear be the thing that holds you back. And then also we have biases and stereotypes, right? If we're breathing, we're biased, and that comes into the room with us. There's this great article called Let's Talk About Sex, Integrating Sex Positivity in Counseling Psychology Practice. It is a wonderful article, and I highly recommend it because of the focus it puts on just knowing your own personal biases and then the impact that those biases can have on the care you're providing. So in this article, there's a pretty extensive list actually of common biases at the intersections of diverse identities and sexuality. I wanted to give you a few examples that are from the article just to look over. So a common bias might be, do I consider clients with physical disabilities sexual beings? Right, that's where we might see our ableism coming in. Or do I assume younger males are oversexed or sexually preoccupied? I label that as gender stereotyping. Have I assumed people who engage in BDSM have an underlying pathology that explains their behavior? And do I assume transgender clients will be unable to find and keep a romantic partner? So that's, the heteronormativity bias that, again, we've all been around for so long. So, I think if these questions, and questions beyond this, if they go unanswered or avoided, it's going to impact the work that we're doing with our clients and our ability to connect with them and their ability to feel safe with us. So lastly here, I wanted to give you a moment to reflect on the impact you might have as you provide care. So I'd invite you to think of, what parts of you contribute to avoidance of sexual material, sex education, sexual assessment. Think about your story or your fears, education, training. What do you have? What do you lack? And just, marinate on that, chew on that for a little bit. We don't have to do much with it, but I do want to invite you into reflection. I want you to think about, how does avoidance impact the interactions you have in therapy or staffing or case consultation? Um, and being able to, again, get curious about that. I think it's helpful to think about assumptions or biases that you might hold regarding sexuality. We all do. Again, I really want to normalize that. And so, if your answer to that question is not applicable, I would tell you to sit with it just a little bit longer, to do some more of that investigating. And then to think, okay, does my intake paperwork or my BPS or initial assessments reflect that I think sexuality is important to be assessing for, that information matters. And, that's a great one. Like, we can adjust our paperwork pretty easily. And that can clue us into, hey, this is important and we do need to be asking about it. So, if we were in a big room together, I'd ask people to raise their hands and answer these questions and invite you into vulnerability, but we're not. So, write these down or look at the slides afterwards on the recording and spend some time thinking about these. Almost done here, promise. So I put together a couple of resources because I've talked on this topic a few times and people are always asking me, where do I go? What can I look at? I am not affiliated with any of these things on the screen. So I'm not a salesperson for any of these. These are just things I have found helpful and have passed along to folks. A couple books I want to mention. The first one is about power play, dominance, and sexuality. I think this author's done a great job kind of explaining it and depathologizing it. So if that's something you come across a lot, I'd encourage you to check out the book. We have some about couples intimacy from the McCarthys. Barry McCarthy is a big name in the sex therapy world. And so kind of a classic book. This third one, the Clinicians Guidebook, is one of my favorites because it's so comprehensive and it has, assessment example questions and assessment, and it's just lovely, and it helps us think systemically. So highly recommend that book. And then of course, Emily Nagoski, she just came out with a new book, I think last week or the week before, but her classic one, Come As You Are, is about desire discrepancy. And often this is a really helpful book for my female clients. There's some podcasts you can check out. I want to mention that there's this great website that is really educational and informative for those who are vulva owners. And so this is often something I recommend to people who don't have a lot of education or knowledge about sexuality, and especially as it pertains to their own bodies, this is a website I'll often send people to because it's just so well done and so informative. And I've also had people ask me, okay, I want to learn more about sexuality and therapy. How do I do that? Do I have to do a certificate? You got lots of options. Maybe you're someone who just wants like a 3-hour training. Those are all over. Two that I've used and I recommend. Again, I've got no affiliation with these, but Barry McCarthy's website has a lot of trainings you can look at, as well as the Modern Sex Therapy Institutes. And then I will say I am affiliated with this slide because this is my book, and it's coming out in probably next month or so. And this book has a lot to do with sexuality, spirituality, purity culture. So if you're someone who's maybe come out of that world and you're trying to make sense of it, this book is hopefully for you. Or if you're someone who, you find yourself working often with maybe more Protestant evangelical folks and you want to understand their experience more or kind of the larger history, this might be something to take a look at. So should be on Amazon in the next month or so here, but wanted to just throw that out there. And wanted to say thank you. If you have questions, I know we just have a couple minutes. I put my email up here. You are welcome to email me. If you want to have conversations, if you want to know about my book, please just feel free to reach out and I'd be happy to connect with you. Thanks.
Wonderful. Thank you, Esther. We're so excited for your book to come out. We do have time for one quick question that came through. Would you have any recommendations for body image work connected to improving relationship and intimacy with others?
Yeah, that comes up all of the time. So what I have found to be helpful is sensate focus. And that's not necessarily, I don't know how many of you know what sensate focus is, but it's essentially what I consider like an exercise to become more comfortable with your body, with your partner's body. It's meant for couples. I often will modify it to have an individual kind of go through the exercises. There are different phases of it. And while it doesn't directly focus on trying to change how someone views their body, it does help with connecting it, paying attention to what you feel, the sensations, temperature, pressure of touch and being touched. And so that is often something I will go to try to create a deeper relationship a person can have with their body that doesn't have to do with how it looks. So that's typically what I go to. Body image is a bit of a sticky wicket. I think you all know, it's work that continues and changes throughout the lifespan. But when it comes to sexuality and the body, that's typically an exercise I go to.
Wonderful. Thank you, Esther. And I know some people wanted to see your book slide one more time just so they can get down the info. Again, I just want to extend a thank you to everyone here and a big thank you to Esther for such an insightful presentation and for all of you sharing in this space with us today. We will be taking a virtual break in the month of March as our clinical staff will be immersing themselves in the community at both the IAEDP on March 21st in Orlando and the ICED on March 14th in New York. Conferences next month. If you are attending any of these events, please feel free to stop by our booth or check out within staff who will be presenting, including Dr. Wendy Oliver Pyatt. We will be right back with our series in April. We'll be joining us with our senior nursing lead, Mariah, who will be presenting on mast cell activation syndrome and its vast implications for the eating disorder population. That'll be on April 19th. Please feel free to check out our social sites for any of the registration information. But again, thank you, Esther. Thank you all for joining us today. It was such a great presentation. We were so glad to have you all here. Wonderful. Have a wonderful weekend, everyone.